All right. Good morning, everyone, and welcome to our penultimate grand rounds of this academic year. Very pleased to be announcing our grand round speaker today, Dr. John Davis. So Dr. Davis is a graduate of the United States Air Force Academy, and after graduation served as an officer in the United States Air Force. He received a master's in philosophy from Colorado State University, and then completed his MD here at the University of Wisconsin School of Medicine and Public Health. The residency program was very fortunate to recruit John to stay here for his IM training, where he excelled as a clinician and as a teacher, and was instrumental in the creation and expansion of our point of care ultrasound and simulation curriculum. John's been an exceptional chief resident, really thriving as a leader, as a teacher, as an educator, and as a mentor to and advocate for our residents within the program. We're certainly very proud to call John a graduate of our residency program. John will be continuing his training here at UW in just a couple of short weeks, starting as a fellow in the Pulmonary and Critical Care Medicine Fellowship Program. So please join me in welcoming Dr. Davis to talk about point of care ultrasound education.
All right. Thank you, everyone. Thank you all for coming. Thank you, Dr. Coyle, for that very kind and mostly true introduction. So we're going to talk about point of care ultrasound for the next 45 minutes or so. Hopefully have some time for questions. I have no disclosures to make. I do not have any financial relationships with any companies, eligible or ineligible. Am I not on? I'm on? Okay. What we're not going to spend the hour talking about is we're not going to spend the hour sort of looking at grainy black and white sort of GIFs. That's good because this one actually didn't turn out and it's sort of all speckled. We're not going to talk about specific exams. We're not going to really be talking about probe positions or anything else. I would love to do that for an hour, but instead we're going to kind of zoom out. We're going to talk about the sort of current role of point of care ultrasonography in internal medicine practice, in subspecialties, and then also sort of among generalist practice. And then we'll sort of talk about how this is sort of being taught, particularly at the residency level and in residency GME. And if we have time, we'll engage in some reckless speculation about what the future might hold. So to begin, we'll sort of talk about the sort of current and growing roles of point of care ultrasound in internal medicine, and then how these skills are sort of utilized in clinical practice. To get us all on the same page, I know that almost everybody has probably heard of point of care ultrasound or heard it discussed at some point. I'll use the acronym POCUS, even though I don't really like the term. I think it sounds a little silly. You might hear it referred to as bedside ultrasound, or sometimes focused or limited ultrasound, something of the sort. But what we mean by it is a focused, sort of goal-directed ultrasonography that's performed usually at the bedside or in a clinic room by the clinician in order to answer specific clinical questions. Importantly, it's not a formal radiologic examination. It's not a formal ultrasonographic exam, and it's not really a substitute for these formal imaging studies, although sometimes it might be used in lieu of those if time or resources or the question is sufficiently limited. Importantly, it differs in two major ways. One is that the person performing the exam, usually the clinician, rarely has formal training, like has gone to school to perform ultrasonography. Ultrasound techs, it's a real profession. It requires real training. Likewise, they don't have specialized postgraduate training in the interpretation of imaging. They're not radiologists necessarily, although sometimes they might be. To talk very briefly about the history, ultrasound was really nothing new. In the middle of the 1950s or so, it began to sort of be developed as a medical imaging modality. Initially in obstetrics, were sort of the first people to bring this into the medical field, followed very closely, depending on what article you read, maybe preceded by cardiology, using it to perform echocardiography. It was really the 80s and the late 80s and 1990s when a couple of technological advances, both in ultrasound technology itself and more importantly in computing and computing technology, that allowed these machines to become much more usable, much more portable, and much more capable of being used to answer clinical questions at the bedside by non-trained specialists. By the end of the 1990s, use was becoming sufficiently widespread that the AMA was sort of forced to weigh in on this. And they declared that, ultrasound did not, or was within the scope of practice of any appropriately trained physician. It was not really the domain of any particular specialty or any particular training pathway. Instead, the AMA sort of left training and education standards open to specific specialties in order to sort of set standards for its use. Inside of internal medicine, some specialties were more rapidly embracing this technology than others. The two that people generally think of, I think, are cardiology and critical care. Residents who are interested in pursuing these subspecialties tend to be very interested in the use of point-of-care ultrasound, tend to be very enthusiastic about its application. Cardiology, for obvious reasons, they're performing not just point-of-care exams, but they're performing formal echocardiography. They may be doing this at the bedside, and then they're also expected to sort of do significant amounts of this in their subspecialty training, as we'll talk about. And critical care, partly for similar reasons to cardiology, also informed a lot by emergency medicine, which was also an early embracer of this technology, particularly in the management of shock, diagnosis and management of hypotension, and other sort of short or other time-limited sort of scenarios. At the same time, critical care and other fields began to sort of lead the charge in performing procedures under ultrasonography and using image guidance to improve procedural outcomes. But while these two fields are the ones that we generally think of, it is kind of hard to imagine a subspecialty in internal medicine now that's not using point-of-care ultrasound in some capacity, or at least has some clinicians that are using ultrasonography in their day-to-day practice. To a very brief tour, like nephrology may be using it in order to perform access procedures. They may be monitoring volume assessment or performing volume assessments in dialysis clinics. They may be doing renal biopsy with the assistance of ultrasound. For discussion of rheumatology and its uses, recommend checking out the grand rounds from Dr. Arneson and Dr. Chidara from a couple of weeks ago. FNAs and endocrinology, even in GI, using ultrasound to monitor colonic inflammation and inflammatory bowel disease or other processes. There are numerous sort of applications for this use in a variety of subspecialties. In moving to generalist practice, there are likewise a huge number of uses that we're seeing inside of hospitals. This is from a Society of Hospital Medicine physician statement on point-of-care ultrasound that was published a year ago. And this sort of goes over some of the many uses that we're seeing hospitalists use this technology for, from cardiac and pulmonary, assessing for ascites and other GI pathology, performing vascular studies, and then using ultrasound to guide bedside procedures. And in addition to these isolated organ system and procedural uses, also seeing it for sort of multi-system purposes, particularly for the management of hypotension, shock, and sort of to aid and assist in diagnosis of acute illness. This is a image that's taken from, I believe this is the American College of Physicians, and this is their position statement on the use of point-of-care ultrasonography in undifferentiated dyspnea in the inpatient setting. This was a review from many different sort of published articles and studies, finding that with a moderate certainty of evidence, point-of-care ultrasound does improve diagnostic accuracy to a significant degree. And that is in addition to the sort of standard pathway, including sort of history, physical exam, imaging, and then also laboratory assessment. Where it's harder to see definitive benefit is outcomes in things like length of stay and improvement in mortality and time to treatment. Those are more difficult things to assess, but if we assume that arriving at the correct diagnosis in a timely manner is an important task for an inpatient physician. It is now the position of the ACP that this is something that should at least be considered. Outside of the hospital and in the clinic setting, this is just sort of a smattering of a huge number of articles that detail uses for ultrasound in the outpatient setting, from monitoring of volume status in heart failure patients, to the assessment of skin and soft tissue infections. The use of ultrasound in resource poor settings, or settings where radiology or formal ultrasonography may not be available, has been described in many different articles and studies. There are protocols in place that allow ultrasound to be used as a suitable substitute for chest radiography, and in some cases it can even be demonstrated to be superior. Even palliative care is talking about the use of point of care ultrasound, particularly as a way to sort of assess whether people might benefit from therapeutic procedures that are causing them significant symptoms. So with all of that in mind, and that sort of brief run through of all of the uses of point of care ultrasound, talk about approaches to sort of ultrasound education, point of care ultrasound education in internal medicine generally, and then in residencies in particular. When I think about this, I think about point of care ultrasound not being as one single skill, but kind of a collection of mini skills that people may have to greater or lesser degrees. You need to have a good amount of medical knowledge about either the organ system that you're examining, or about the sort of broader clinical scenario in which you're sort of working through a differential. There are the technical skills, the technical skills, the ability to obtain a usable image in a patient with varieties of body habitus, anatomy, and so forth, and also the ability to work an ultrasound machine. There's image interpretation, combination of sort of pattern recognition, understanding of the modality that you're using, and the ability to sort of arrive at a correct interpretation of what it is that you have captured with your machine. And then finally, the ability to integrate all of that information into the broader clinical context in order to sort of to advance care. I sort of have a shading from red to green. Medical knowledge and clinical integration are something that we're doing in internal medicine all of the time anyway. This is something that we're fairly good at teaching, and something that a lot of clinical teaching and residency revolves around. It is these other sort of mini skills that are difficult, especially for novices in point of care ultrasound, to learn, sort of technical skills of working a machine, acquiring images, and then also being able to interpret those images correctly. If you are a physician who's out practicing in the community, you've graduated from residency, and you want to learn more about point of care ultrasound, you've got any number of options to do so. In fact, there's really as many options as rigorous or as light as you might desire. There's sort of computer-based simulators that are available. You can go to weekend courses and sort of have a little bit of hands-on introduction and training. Both ACP and the Society of Hospital Medicine, the latter in combination with CHEST, have sort of certificates or pathway programs that generally involve some degree of didactics, some in-person sort of ultrasound teaching, followed by the building and sort of submission of a portfolio. And then there's sometimes a knowledge assessment attached to that as well. There's online versions of this through certification academies. The National Board of Echocardiography, the organization that certifies echocardiographers in cardiology, now offers one for critical care, a board exam, and sort of a board certification pathway in critical care. And even you can even go up to this sort of level of completing a fellowship after the completion of residency training. Which one of these is the means and the method that's most appropriate to use for somebody who's learning ultrasound? I think a lot of that depends on how you sort of look at point of care ultrasound, or what your sort of broader idea of what POCUS should be ends up or is. One is sort of represented by this circle on the right of the screen. So one is sort of thinking of point of care ultrasound as an extension of just the physical exam. Just as we will listen to a patient's heart, we will listen to their lungs, we may percuss or palpate their abdomen. Using an ultrasound is just an extension of this, where organs or other things are assessed just using an ultrasound machine. Like a physical exam, it's something that's performed routinely. It's something that's correlated with a history. It's something that is interpreted subjectively at variety or at varying levels of skills among different clinicians. So some clinicians may be fantastic at performing a volume exam, for example. Others may not be quite as good. Likewise, some may be very versed in using an ultrasound. Others might just use an ultrasound for very simple things or for very simple assessments. An alternative view of this, and these aren't necessarily just my ideas or my frameworks, is sort of viewing point of care ultrasound more of as something like a procedure, right? So thinking of this, or maybe as like a limited ultrasound or a limited imaging study. This is viewing it as a specialized skill set, as something that has its own indications, as something that has its own risks, as something that has its own benefits, and that's something that should be standardized and protocolized. Imagine, for example, putting in a central line on a patient where you're doing the same thing, the same ways every time. When you're initially doing it, you're taught how to do it, you're supervised for the first periods of it, you demonstrate competency, and then you go on to repeat that procedure over and over and over again. What do these look like in practice? To sort of pick two examples as sort of illustrative cases of these. Sort of point of care ultrasound as a procedure, we might think of how cardiology teaches its fellows to perform echocardiograms. Now, this is not quite a perfect example because this isn't just a point of care study. These are formal imaging studies interpreted by experts, but the curricula and the standards that cardiology uses are illustrative of maybe the extremes of this approach. How do they do it? They set guidelines, national and international guidelines on knowledge that clinicians need to have, skills they need to be able to perform, competencies in systems, and there's graduated standards depending on what your practice is going to be. There's minimum procedural numbers, but beyond that, there's a requirement to demonstrate some sort of formal knowledge or skill. And this all culminates in board certification and a requirement to maintain certification once you reach a certain level. This is very rigorous. This is great. This also requires a great deal of both educational, curricular, and then clinical effort. A high number of faculty, a large amount of time. If you are a hospitalist who is looking to use an ultrasound in their day-to-day practice, you're not just using it in one single organ system, but needing to apply that level and that standard to all of these potential different fields obviously creates some barriers. Now, you could say that those barriers are entirely appropriate and that a person should not be using an ultrasound machine to perform all of these different exams or procedures and only doing the ones that they've demonstrated competence and capability in. And that's a totally valid way of looking at things. A demonstration of the opposite sort of philosophy related to what a point of care ultrasound is as sort of an extension of the exam, I think is demonstrated by what's going on in some medical schools in the United States. So I list there the University of Utah, UC Irvine, Temple. These are some, but not all of medical schools that have started to do this over the past several years, who are handing point of care ultrasound probes to their incoming medical students, sometimes before they've seen patients or even begun rotating on the ward, some at the beginning of the first year and in their preclinical curriculum. Obviously, these medical students, they're not experts in ultrasonography. They're not experts in anything yet. They're beginning their clinical training. but they're using ultrasound from the beginning, integrating it into their studies of anatomy, integrating it into sort of their early physical exam courses, and developing these skills alongside and sort of in tandem with those other sort of physical exam and clinical skills. There's recognition in these that everybody is going to be using these with variable abilities, with variable skills, with variable knowledge levels. And there's mentorship related to that, and there's formal didactics, but there's also sort of an approach that practice to this sort of thing makes perfect. As you may have figured out from my description of these, or maybe just because I've made them circles, these two things aren't exactly mutually exclusive of one another, and they do kind of inform one another, and there is significant overlap between these two views and approaches of things. But where you sort of feel like you fall inside of this Venn diagram is going to dictate what kind of training program you feel is appropriate and what kind of training program you build. And across different residencies, there is a huge variety of different curricula that people have constructed. Inside of residency, we have a few things going for us that are very, very helpful. First of all, many studies have shown that point of care ultrasound is a very teachable skill. Even with relatively short periods of time, those technical skills and those ability to interpret images can improve very, very rapidly. Sometimes in the course of even sessions as little as an hour, people have demonstrated significant improvements in the ability to acquire usable images and then to accurately interpret those images. More and more residents are coming in having had exposure to ultrasound training in medical school, even if they're not getting handed a probe on the first day of M1 year. Over half at this point of medical schools have some form of ultrasound curriculum. And depending on what survey you read, that may be as high as about 70% or so. Residents are very interested in learning this kind of thing, more so than a lot of other skills that we are required to teach in residency. Generally, in surveys run from 70 to 90% of people who are either interested or very interested in improving or acquiring point of care ultrasound skills. And regardless of what career path they're going to be pursuing, there's a good chance that they may find some use for those skills in the future. So that's all good things, but there are significant barriers to sort of building a perfect program. The first, I think, and this is a very important one, is that resident time is extremely valuable. It is a very precious resource, and it is very finite. Any sort of educational program takes time, and an educational program that is going to teach technical skills is going to require more time. In addition to that, and sort of related to it, is that just as these skills are very teachable to residents, they also atrophy very quickly. Things learned over the course of an hour are lost over the course of a week. And the need to sort of continually reiterate, to continually rehearse, to regularly practice those technical skills, to regularly reiterate points in sort of image interpretation and clinical integration is a very important part of any curricula and something that is difficult to do, especially in an already time-limited environment. In internal medicine, particularly, especially more than some other subspecialties, career goals are very, very diverse. The future endocrinologist needs to know much different things about ultrasound than the future cardiologist, than the future palliative care physician. Building a curriculum that's able to accommodate all of those different career goals is something that is quite difficult to do. This equipment is expensive. Those small ultrasound probes, the real reason that we're starting to see medical schools hand those out is that they're dramatically less expensive than a lot of the ultrasound machines that we have in the hospital right now. But even those small, relatively inexpensive ultrasound probes are $2,000 a piece or so. And that's not including the back-end technical support, integration with clinical software, and other sort of needs that we have. Standard ultrasounds running somewhere between $7,000 to $10,000 for handheld probes. Those machines on wheels with laptops, those are closer to $30,000 for a front-end machine. If you want to acquire enough of these to support an entire internal medicine residency, which may be as small as 10 or as many as like 150, some programs have residents, you're going to need a lot of money and a lot of resources. Finally, and this is a problem that we have now and that will probably decline over time, but there are limited numbers of faculty members who are comfortable with this, who are comfortable performing point of care ultrasound exams and are comfortable in teaching others to do so. There are various ways that people get around these, and there are various sort of curricular models that you'll see in point of care education. This is taken from a review published in 2017 that's focused on the curricula of 4 different centers: Case Western, University of Minnesota, Oregon, and then Boston. And this was detailing the different things that these programs were doing in internal medicine education. I kind of break down what's going on in these programs as sort of 3 broad buckets of things. One is sort of a didactics-based approach, sort of maybe a lecture, maybe a web-based, it may even be hands-on, but it's relatively short, 30 minutes to an hour. It's generally delivered in a more or less sort of standard educational format, and it may be able to be done with relatively low investment over and over and over again over the course of an academic year. There is a workshop model. This is generally a bigger logistical lift, both in terms of finding resident time and then also having the skills, not just having the skilled people, but also having the equipment and resources to put on. These generally will block out somewhere between, half of a day or at least a couple of hours, in some cases all the way up to a week in some programs, to sort of sit down to talk about the technical skills, image interpretation, and medical knowledge pieces of things, and then to work either with sort of simulators, on task trainers, or with standardized patients on practicing and developing those skills. A third model, and the sort of third big bucket that I put things into, is the sort of elective model, or the idea of having an optional rotation, an optional educational experience that learners who are interested in this particular thing can rotate on and build additional skills. Going back to sort of our idea and sort of our philosophy of where these things might fall, depending on where you think all of this is, different models are going to appeal to you more. All internal medicine residencies believe that residents should be able to accomplish a physical examination, for example. So if you fall on the right, on the far right side of this Venn diagram, you're probably going to feel that residents should have some ability, all residents, regardless of what they're going into, should have the ability to sort of use an ultrasound in certain clinical circumstances. If you believe that this is primarily a procedure or sort of a procedural thing, you may limit it more to those who are interested or are taking an elective. I don't want to speak for everybody involved in our POCUS curriculum, because I think that there's a lot of disagreement and a lot of healthy sort of opinions about where we should fall on this. But if I had to say, I'd say that at University of Wisconsin, we're kind of falling right on the edge of this sort of overlap between the sort of procedural philosophy and the examination philosophy. We do think that this is primarily something that augments, improves clinical examination and clinical decision-making, something that should be performed routinely, something that is appropriate to be done even at varying skill levels, but is still informed by kind of the best practices of a procedural-based approach. Understanding the risks, understanding the limits of an ultrasound curriculum, having equipment and having material that's integrated with our health system and other software, and something that residents should be able to demonstrate some degree of skill with in order to use clinically. To talk more about our curriculum in particular, to zoom back about 6 years ago now or so, our ultrasound training was a little bit sparse. This was a slide that was built a number of years ago, but sort of summarizing what was going on in 2017, formally inside of the residency. We had required central line training for every resident. We had a procedures course where residents could perform image-guided procedures. We had ultrasounds available in the medical ICU, and there was the option for sort of residents to engage in some learner-directed learning, both in our ICU here at UW and then also at Meriter. But there was clearly a curricular need 6 years ago or so about improving our ultrasound education at the residency level. The father and mother kind of this program, for lack of better terms, Dr. Tim Rowe and Dr. Katie Fell, who identified this actually as interns as this curricular need. And as part of a teach project, I began to develop a required workshop for all first-year residents, and then also began to develop a resident-led POCUS curriculum that would extend across the entire residency. This intern POCUS workshop obviously follows sort of a workshop model. All PGY1s who are going through residency at UW will attend it, all of our categorical and primary care residents. It's a combination lecture and workshop format where we sort of alternate between those two skills that are most difficult for novices, the technical skills and the image interpretation, and give everybody who's going through their first year of internal medicine residency a foundation in those skills so that they can carry things forward. Residents lead the lectures, and then faculty, fellows, and chief residents will sort of act as instructors to teach residents those technical skills. You can see Dr. Andrew Davis, one of our VA chiefs, walking an intern through scanning on a standardized patient. With the support of UW Sim Center, we also have access now to these POCUS simulators, which are very useful didactic tools. They're not just second best in addition to standardized patients, but they offer lots of sort of educational benefit beyond just scanning on a standardized patient. You're able to see what a 2D ultrasound image is actually displaying or examining in 3 dimensions. You're able to import pathology into these systems. It really is a very powerful tool and something that we're very fortunate to have. After the PGY1 POCUS workshop, after people have a foundation, they do have an ability to sort of use these on the wards, use these on ICUs. We are also able, with the support of Middleton VA Hospital, to offer a POCUS rotation as an elective to residents who are interested in building these skills and developing them further under mentorship, guidance, and education. There's diagnostic scanning on patients who are in the hospital, serial monitoring on patients who may be undergoing either procedures or medical treatment. This is also a service that offloads our inpatient medicine teams by performing many of our bedside procedures, and also gives those residents who are interested in building those skills for future practice the ability to do so. We're also lucky enough to have dedicated point of care ultrasound staff who scan frequently, who are very, very dedicated and excellent teachers who can mentor residents during this rotation. In addition to those things, we've been able to integrate point of care ultrasound lessons, image interpretation into our morning and senior reports, so regular didactic sessions. We still offer the hospitalist medicine procedure rotation. Then we're also fortunate enough to have many subspecialty electives, echocardiography, FNA clinic, and so forth, that allow residents to sort of investigate further and tailor their ultrasound education to their future practice expectations. We have handheld ultrasounds dedicated or available to all residents housed in our house staff library that are able to be used on the wards and then also as cross cover in all of our ICUs at Meriter, UW, and the VA. We have access to ultrasound and then also in the VA emergency department as well, where the UW EM faculty are also able to facilitate ultrasound education. This year, as you may have heard from Dr. Floden's grand rounds earlier this month, we did move to an X+Y curriculum, which involved a whole lot of sort of schedule changes and turmoil. But the upshot of it for this talk was that it finally gave the residency protected didactic time. 1 day every 4 or 2 days every 8 weeks, where residents are able to be protected and to focus solely on educational projects. One of the things that we've been able to do at that time this year is to add more simulator training for PGY2 residents and sort of facilitated by PGY3s. We've been able to incorporate ultrasound into those clinical scenarios as well, primarily focusing around things like diagnosis of acute dyspnea or diagnosis of hypotension, management of shock, and use in resuscitation as well. All of these things sort of combined have led to us from going from a relatively sparse ultrasound curriculum 6 years ago to the point now where we have pretty broad exposure, both in terms of dedicated didactics and also in terms of things that learners are able to do and learner-directed experiences over the course of their residency. Not unique to our residency, but something that is very special about it is that much of this is run, facilitated, organized, and directed by residents. So after Tim and Katie, we have had this wonderful group of people who have helped carry this curriculum forward now into year number 6. And I think if anything, things are still continuing to grow and improve. Some action shots of people, some portrait shots of people. These are all of our wonderful POCUS residents. Talk briefly about the future. To begin with sort of the future and particularly the future of ultrasound education in our department. So next year in 2023 and 2024, Mike Hohen and Dr. Kelly Lavin are going to be unveiling a outpatient point of care ultrasound curriculum. It's going to start at Union Corners next year with the primary care track residents. And it's a supplement to our current sort of residency-wide point of care ultrasound curriculum that all residents, including our primary care residents, go through. Focusing on outpatient examinations, MSK ultrasound, hepatobiliary disease, skin and soft tissue infections, common applications for point of care ultrasound in the outpatient clinic, and also using ultrasound in outpatient procedures and procedural guidance. Our UW POCUS curriculum continues to grow and expand over the course of this year, and going forward, we're continuing to expand our bedside resources. We are already using our didactic days with senior simulation in order to sort of reinforce principles in point of care ultrasound. And we're continuing the PGY1 POCUS workshop. The hope is we'll be able to expand these workshops, maybe to include senior seminars, and then also to further outreach to the medical school. Been able to support the intern prep course this year in their sort of curriculum, and we're hoping to continue to do that in the future. For those of you residents and fellows who are listening, there's ongoing scholarly activity in point of care ultrasound. Talk to Dr. Chauhan after the lecture if you're interested in learning more, or you can check your inbox because it may be arriving in your inbox very soon. To talk about the future more broadly, very briefly, and really only for a slide or so, we can sort of speculate as to where all of this is heading. We sort of think about where we were talking about all of the applications in terms of subspecialty practices, all of the applications in hospitalist practice, all of the applications in the outpatient setting. The question is, what will the educational requirements look like in 5 years or 10 years? Back in 2012, so over a decade ago now, the American Board of Emergency Medicine began mandating that all emergency medicine programs need to offer point of care ultrasound training to all of their residents. It is now part of all emergency medicine curricula. It is on emergency medicine boards. It's an expectation that emergency medicine physicians will be able to perform these exams to a certain degree of adequacy. Hot off the presses in 2023, family medicine began to make these same requirements where residents at least need to be exposed to and have experience in point of care ultrasound over the course of their training. And that includes not just emergency medicine and inpatient medicine, but also obstetrical ultrasound as well. The question I think that is on everybody's mind is internal medicine going to adopt this standard as well? I'm not entirely sure if we're headed in that direction or not. We're sort of cutting against two separate trends. One is a move in internal medicine education to sort of focus more on the skills and abilities that residents will need in their future careers. And so that will be recognizing that that will be different for every resident. At the same time, there is a sort of move that ultrasound, the use of ultrasound is becoming more expected and more of a clinical standard. You can see how these two things might be sort of cutting against one another. But at least for now, at least in the 2022 standards, there's no requirement for point of care ultrasound experience per se, rather that developing expertise on the procedures and on the point of care diagnostic and imaging studies that are relevant to a resident's future career are what's expected. So with that, hopefully we've covered most of these things to a greater or lesser degree, especially all these chief ones. These things end with a number of thank yous, and I am no exception to that rule. All of our POCUS residents who are on those slides previously, I won't read all of your names, but all of the amazing work that you do, both in terms of educating other residents and then also sort of building and supporting this curriculum. Our team at the VA, particularly Doctors Aldrich, Browse, and St. Peter, who are huge supports for our residents who are rotating through that program. Tim Rowe and Katie Fell for developing this program, and then Dr. Alex Wick, Dr. Melissa McDonald, Mike Hohen, Kelly Lavin, the UW Simulation Center, who supports us in so many of these things, and then also the Clinical Teaching and Assessment Center, who help us with standardized patients, Dr. Coyle, Dr. Zielinski. The Teach Pathway is really responsible for all of this curricula. All of our APDs and education team for their support. And then of course, every resident who has been subjected to this curriculum, who has put up with all of our educational endeavors. Thank you so much for your support. For Rachel Wenger, who married me 7 years and 11 months ago, 7 years and 11 months ago, and who also helped me with these slides and making them look reasonable. And then finally, to all of my co-chiefs, thank you so much for everything over the course of this year. I'm really glad that we got to do this together. I'm glad that we get to call each other friends. So thank you all for paying attention. We've got time for questions. Awesome.
All right. So first, I want to commend John for a really terrific grand rounds. I think a wonderful history, of POCUS, both here and elsewhere, and a nice view into the future. And I think a lot of generalizable points about how we think more broadly about teaching skills to trainees, POCUS and otherwise. So we do have time for questions. I guess we'll start with people here in the audience. I can walk around with the microphone. I see a future fellowship PD already. Got to put him on the spot.
John, excellent job. And I mean, I love the morphing of that procedure examination, bubble. As a training program, trying to balance resources and HIPAA, to be perfectly honest, how do you think programs of all levels should be recording images, storing them, and who should be reviewing those? Because I feel like the sim centers are awesome. The models are getting better. Like you said, atrophy of skills. When you anchor your diagnosis on something at the bedside at 2 in the morning, how do you go back and give a feedback on that. That was the accurate diagnosis made? Was it? I just want to know your thoughts on it with all your expertise in this area.
If I had unlimited time, money, and resources, I think that all right, awesome. Emergency medicine sets a fairly good example of this, where there are over 100 emergency medicine point of care ultrasound fellowships who have dedicated faculty, post-residency faculty, who can devote a fair amount of time to image review, education, QI, and QA. So if an emergency medicine resident is performing a fast exam at 2 in the morning in the emergency department, those images are recorded on a PACS system, and then they are reviewed by a faculty member at some point who's able to offer that resident feedback and also grade the quality, skills, and abilities of their image acquisition. Likewise, all of that information goes into the EMR. So images are usually recorded, the exam is recorded and documented, and that likewise is sort of, it offers opportunities for feedback, critique, and room for improvement. All of that requires a lot of infrastructure, and it doesn't happen overnight. So emergency medicine began mandating ultrasound education over a decade ago in 2012, and that was after more than a decade's worth of interest, research, and significant clinical interest in developing and expanding point of care ultrasonography. So it was a 2-decade process to get to where they are now. Will internal medicine look like that? I think that would be great and that would be nice. There's a lot more internal medicine residencies than there are emergency medicine residencies, with a much wider array of sort of available resources. And then again, like we mentioned several times, career goals are much, much more diverse. So if we have that sort of, putting that system in place would be something that would take years, maybe even decades. That would be the dream, and that would be the hope. And I think that that would sort of be the best practice, having faculty available who can do regular QA of scans and imaging, able to review exams performed by residents, regardless of the time or location that they're performed. Unfortunately, we live in a world with finite resources and energy and so forth.
Thank you, John. Just an awesome presentation. I have yet another question about resources, which is, as our Department of Medicine Education Committee considers funding projects like this, I think we all want to know that there's some change in patient outcome because of this. Presented one study where it looks like the length of hospitalization was the same. I imagine there's a lot more studies out there that kind of show us that this is crucial and important and changes outcomes in some way, but I wonder if you could comment about that.
Yeah, the holy grail of any sort of educational project in medicine is demonstrating patient outcomes, and it is not always easy to do so. So thinking back to that, and that was the all the way back to that ACP slide, if you have 10 patients who are coming in with unspecified dyspnea, you're arriving at a diagnosis more quickly and arriving at the accurate diagnosis in, like, let's say you're doing it, in 3 patients out of 10, you're arriving at that number quicker, but, or more accurately, but showing that leads to improvements in hospitalization length, mortality, and so forth. It's just harder to demonstrate that over time. I think that intuitively, at least, there's arriving at an accurate diagnosis is probably an important step in patient outcomes, even if you're not able to sort of demonstrate that to a sufficient degree of evidence. But yeah, that is a problem in all of these studies. I agree.
I think a kind of similar question from Dr. Lucy on Zoom. Can you speak to the need to create a permanent report of POCUS examinations for the EMR? What is the process? How have places sort of handled that? Having an official record of the images?
Yeah, so Best practices is generally that you have the machines that you are utilizing connected to a PACS system, and that this PACS system ideally is integrated in some way into the EMR. Also that examinations are recorded, documented, and that an image interpretation is also placed into the chart. That requires a certain amount of interface, both with IT, hospital support, clinical support, and then also with the EMR itself. That also has billing and other implications.
I think another great question from the chat, and then we'll come back to the audience, from Dr. Meyer. So great talk. Thoughts on a common practice of siloing off POCUS and bedside procedures to a single rotation or service with a small number of staff who rotate through this. Concerns with general hospital staff not on that service losing their own skill in performing bedside ultrasound and procedures leading to diminishing skill set. So kind of concentrating that skill in a smaller number of people by having specific services. I don't know if you have any thoughts on that.
I think that that's a way that certain programs go. And I think it comes back to that broader idea of what do you view point of care ultrasound as? If you view this as something sort of more akin to a procedure or something more formalized, protocol driven, and something that requires a level of competency in order to be used responsibly, I do think that siloing, that narrowing both of faculty and then of residents who are performing it is appropriate. Whether our program moves more in that direction, is tugged in that direction, I think that is something that will be considered over time.
Other questions from the audience here?
Thanks, Dr. Davis. That was a great talk and so thought-provoking. And I'm really impressed with how you use that conceptual model to help us understand how we conceptualize a skill can really inform curriculum development and measurement. So I really appreciate you bringing that out. My question is a little bit different about resources, but sometimes I think about some community programs across the country that might not have the monetary resources to put a POCUS curriculum into place. Let's say the ACGME does say we need to do this. I wonder if there's conversation or ideas that you have on how we can help spread the wealth, so to speak, for all programs in order to be able to do this with the high cost, especially to the equipment.
That's a good question. Going back to Dr. Zakowski's point, it would be a much easier sell to hospital systems if we were able to more reliably demonstrate that there are financial incentives to sort of to put these infrastructures into place, so that there is a reduction in length of stay, there is an improvement in mortality, that costs go down if you invest in these things. I think that until that is demonstrated, if it is, it might be a hard sell, particularly for sort of the community programs and so forth. The good news is that capable equipment is becoming less and less expensive. So those the probes that were being issued to medical students, those butterfly IQs, those are significantly less expensive than the ones that we have by, it's only about 1/5 of the cost or so. So that barrier might be dropping. I think though the larger barriers are the other things we've been talking about. Do you have the integration with your EMR? Do you have faculty who are in place who are capable of teaching this information and doing so reliably? Are you able to offer, sort of feedback and reliable education to residents? Those things are more difficult. I think that they'll also begin to resolve over time as more and more residents are getting this training in their academic residencies and moving out into the community and becoming educators there. At least that's the hope.
Oh, one more question here. I know, I am. Make sure I have my phone so they actually are officially counted, gotta get that 10,000.
Thanks for the talk, John. So one of the challenges that I've faced as a senior resident in those learner directed settings, so like the ED and the cross cover setting, is that our time really is limited when we're in those situations. And when you're not in the formal POCUS pathway, it takes a while to actually acquire the images that you think might be usable. So what would you say to the senior resident who's in that situation with an intern who's trying to manage a lot of different tasks and maybe doesn't want to be there as you're trying to get your images?
Yeah, one of the corollaries that resident time is extremely valuable to a residency program, but time is also extremely valuable to residents themselves. And if it's a question of are you going to be able to see the number of patients that you need to before your shift ends and get your notes done and go home at a reasonable hour versus staying until well after 10 p.m., but messing around with the ultrasound, I think it's a pretty easy choice for a lot of residents to make to forego those opportunities. The answer to that other programs and our program to a certain extent have been able to sort of avail themselves of is these sort of protected rotations. And those offer some time, but it's not nearly adequate. Expanding them to sort of have dedicated time to do ultrasound while you're on other services and in other wards would be wonderful. But again, resident time is valuable, not just to residents, not just to the program, also to the systems in which they work. And not always, that's not always something that's feasible.
So one last question from online raised by two people. Any concern that sort of POCUS will lead to a further deterioration in physical exam skills among physicians? So there's only a finite amount of time for something like bedside warning and teaching. I guess the sort of opportunity cost, what effect would you imagine this would have on physical exam proficiency?
Yeah, that is an excellent question. That's something that sort of ended up on the cutting room floor as I was designing the talk. I am of two minds about this. I do think that there is, particularly in sort of the undergraduate setting, a whole lot of utility in using these to improve the physical exam. There's no better way of demonstrating how small the lungs actually are relative to your rib cage than putting a probe on your standardized patient and seeing where their lung stops and their liver starts, for example. So you don't have patients sort of auscultating the retroperitoneal space by accident because they think that that's how big the lungs are. I think that that's a way of improving a physical exam in certain cases, but again, it costs time and it requires investment, and that could lead to sort of a change in emphasis in physical exam education. More broadly, I think that there's probably some, how do I want to say this? There's a lot of discussion about the utility of the physical exam in modern clinical practice. I think that it's a reasonable position for some people to take that much of the physical exam is unreliable, is outdated, or other things like that. I have never seen any of those clinicians put their money where their mouth is and refuse to examine a patient. And I think that it is an incredibly valuable thing to teach and learn. And I don't think that teaching these skills should come at the expense of teaching physical exam, both to undergraduates and then also to residents.
So I want to thank John again for a terrific Grand Rounds presentations. Lots to think about the future of, skills-based education, POCUS, bedside diagnostic reasoning. So thank you for a wonderful presentation. Thank you everyone for attending in person or on Zoom, and we'll adjourn there. Thanks everybody.
Thank you all.